Good evening, everybody, and welcome all of you to this live program. Today, our guest of honor is Professor Philipp Kasten from Tuebingen, Germany. Philipp is a board-certified orthopedic surgeon specialized in shoulder and elbow surgery. He received his PhD in regenerative medicine at the University of Heidelberg in 2007 and was professor for the experimental orthopedic surgery at the University of Glenoid during 2011 to 2013. Now he's partner in private practice at the Orthopaedic Surgery Center at Tuebingen and also associate professor at the University of Heidelberg, Germany. Dr. Kasten did his medical school and residency in Germany and the US. He was elected for travel fellowships at the University of Heidelberg and also worked with Laurent Lafosse in Annecy, France during 2007. Philipp was president of the German Shoulder and Elbow Congress 2017 and is also the board member of the German Shoulder and Elbow Society and the European Shoulder and Elbow Society. He received several awards for his research and has published more than 100 peer-reviewed articles and several chapters in textbooks on shoulder and elbow surgery. So today, it's my great honor to introduce you to Professor Philipp Kasten from Tuebingen, Germany. Over to you, Philipp.
Yeah, Heiter, thank you very much for the invitation. I think you've created a great format to share our knowledge, and it's my honor, and I'm very pleased that I can give this speech and this lecture to you. My topic today are the principles of total shoulder arthroplasty and comparing the anatomic and the reverse designs. As you know, there are different kinds of diseases that require total shoulder arthroplasty. There is this classic osteoarthritis, you can see on the left X-ray, and there's cuff tear arthropathy. And what are the differences? Let me take you through this. In classic osteoarthritis, you have a wear of the cartilage that if you compare it to a wheel, it's like a puncture and the air and the rubber is gone. If you look at the X-ray, you still see a space between the acromion and the humeral head that is filled by the supraspinatus. And in the course of the disease, you will see continuing narrowing of the space and growing of this big humeral osteophyte. But still, the supraspinatus is intact, and that's why the space remains the same. The shoulder is a joint that has a very large head that is balanced on a small glenoid. So you require an intact anterior and posterior muscle to create a force couple. In the course of the disease of osteoarthritis, you will have a wear of the posterior glenoid that will cause a posterior subluxation. And this may limit your external rotation. If you continue to use this wheel after your puncture, then you will have damage to the rim, as you can see here or here. If you translate this problem in anatomy, this resulted in a classification by Gilles Walsh, who put this posterior wear in B1 and B2 glenoids. And if you have this posterior wear, as I said, you may have limitation of your external rotation, and you can look at this in your clinical examination. What is the ideal time for surgery? Obviously, if you look at this CT scan, you can easily implant a glenoid component. This becomes more difficult if you have more posterior wear and dislocation. This might be a problem, and in this case, it's just impossible. So it's ideal if you have enough bone for your glenoid component to correct the posterior wear and recenter the humeral head. The biomechanics for the shoulders are pretty difficult because you have this large head that translates on the glenoid. This causes some motion and maybe loosening. And this motion was called rocking horse phenomenon. And if you implant the glenoid not in this position, but in retroversion, you don't have this distribution of the shear forces, but a stress riser in the posterior part. And this might be the reason for early loosening of your glenoid component. Let me show some examples to repair the tire and the rim, how you should not do it. In the shoulder, it's best to replace the humeral head and the glenoid. By doing this, you will have the best pain relief and the best function. If you only replace the humeral head, you will have inferior results. This has been shown in multiple studies. So that's an X-ray of a replaced shoulder. You can see that the humeral head sits perfectly on the bone stock. You don't have too much loss of bone, and the glenoid that you see only in the transparency because of the cement that's around the pegs, as you can see here. So what outcome can you expect from anatomic total shoulder arthroplasty? Actually, you can expect pretty good outcome. This is an image of a lady 10 years after total shoulder arthroplasty, and she's still doing pretty fine. If you look at the outcome in registries, you can see that the revision rates are a little bit higher in total conventional, but in total reverse arthroplasty. But this might be related to the fact that it's difficult to revise total reverse shoulders as compared to total conventional shoulders. If you look at the observation years, you will have 2% revisions in 100 observation years. And this is pretty good. The reasons for revisions in anatomic shoulder arthroplasty are humeral head component problems, humeral and glenoid problems, and head-only problems. And if you look at the reasons, instability and dislocation is the main reason, followed by rotator cuff insufficiency, loosening and lysis, and finally implant breakage and infection. The cumulative risk is 10% in 7 years, and the way it was revised is mainly in a total reverse. The reason, if you look at the glenoid problems, sum up to 20%. And the reason why that is again the rocking horse phenomenon that I've already told you. And what's the problem with loose glenoids? It can cause pain, loss of function, and finally glenoid bone loss. Which glenoids are better? The cemented or the cementless? As you know, most surgeons prefer cementless implants because by doing this, they can avoid the process of cementation and save some time. However, the registry tells us that the cemented ones are much better than the cementless ones. This is in accordance with other registries, like the New Zealand National Joint Registry, that's showing that cemented glenoids are superior to uncemented ones. How does cement work? Cement is no glue, as Sir Charlie told us. It works through its anatomical form and gets its stability only through penetration into the cancellous bone. We invented a way to improve cement penetration into the cancellous bone for the glenoid, as you can see with this rubber device. We tested this in vitro and in vivo, and we could show that the cement mantle is much better with using this device. What is the theoretically ideal cement mantle? The aims are sound penetration into the cancellous bone, a complete cement mantle of about 1 to 2 millimeters, no cementing defects, and no organic material between the cement and the polyethylene. We can improve cement penetration by using a jet lavage, and I highly recommend this. If you use just a syringe, you will have inferior results, as you can see in this image. And it's a good way to open the sclerosis so you can have infiltration of the bone into the cancellous bone. For example, here you see the same in the hip acetabulum. It's better not to use highly viscous cement, because if you use this, you will have inferior penetration of the cement into the cancellous bone because it's pushed back by the blood pressure and the blood. It's better to use highly viscous cement. As you can see here, it's good to wait until the cement starts hardening and it's not sticky anymore. It's also useful to use the newer generations of polyethylene glenoids, the cross-linked polyethylenes, because they have much lower revision rates, as you can see here. So the summary for anatomic total shoulder arthroplasty is that that the revision rates are low. Instability and glenoid loosening are main problems. And if you have good indications, you will have good results. Let's move to the second indication, the cuff tear arthropathy. This is a problem not only of osteoarthritis, but of a tendon rupture. As you can see here, if you use the example from the car. If you have a tendon rupture, as like shown in this image of the trousers that are torn on the knees, the tendon ruptures can increase, as you can see here. Over 25 to 50% progress over time. So if you compare the space between the acromion and the humeral head, that at the beginning there's some space left, this will decrease over time because the supraspinatus is not there anymore. This causes some symptoms that are classic. You will have an increased force of the deltoid because of the cuff tear. You will have superior migration of the humeral head and superior glenoid erosion. So the solution was to create arthroplasty that was constrained, like this Fenlon arthroplasty. Fenlon is this gentleman on the left. In these arthroplasties, the joint was constrained, and this caused a lot of strain on the glenoid component and finally caused loosening. So these really constrained implants failed. And the solution came by an arthroplasty by Grammont, where the joint is not fully constrained, but semi-constrained. And the first shoulder is shown here in this image. And this was a kind of revolution. And you can see by putting in these implants, you will have very good clinical results. The concept is an increase of the lever arm from the anatomic lever arm to this lever arm, because by doing this, you can recruit much more fibers of the deltoid. You can see this in this transsectional view with the center of rotation being here in the anatomic position. You have this amount of muscles that is recruited. And by moving the center of rotation more to the glenoid, You have much more muscles you can use to lift up the arm. The prerequisites for implantation of a reverse total shoulder is that your deltoid is still innervated, that you have enough bony substance at the glenoid, and you have to look at the acromion whether it's stable or whether you have a mesocromion or osteolysis of the acromion, like in rheumatoid arthritis. The patients shouldn't be too young because of some limitations that I will show you in a second. What about the outcome? I made a meta-analysis of studies dealing with reverse total shoulder arthroplasty, and it's impressive how much the active flexion improves. It improves by 60 to 70 degrees. The constant score improves with about 40 to 60%. However, the revision rate and reparation rate is higher with 5 to 18%. So the intermediate term outcome is relatively good with low complication rates, but however, a little bit higher than in uncomplicated anatomic total shoulders. So there's no free lunch, as you know. If you increase the lever arm, you will have lengthening of the glenoid. And if you overtension this muscle, over time, the muscle will lose function and will degenerate. Secondly, with this 155 design, you may have notching of this inferior part of the humeral component with the glenoid neck. And finally, if you move the center of rotation medially, you will have a decreased lever arm and reduced tension of the infraspinatus and teres minor, and this reduces the external rotation. If you look at the intermediate or long-term results, and there's one study showing that there are two drops of the constant score, one after 1 to 3 years, maybe to radiolucent lines or an infection, and after 6 years, we will have a reduction of function, maybe secondary to loosening or secondary of the fatigue of the deltoid. What about the radiologic results? You will have glenoid loosening very rarely, 0 to 6%, humeral loosening even lower, 0 to 2%. So the intermediate rates are very low. What about the notching problem? If you look at the classification, you can have minor notching, not touching the inferior screw. You can have notching of the inferior screw that can cause some metallosis and severe osteolysis. And finally, you can have large scapular notching. And if you look at the incidence of notching, this is pretty high in the classic design, ranging from 63 to 60%. Notching degree 1 to 2 makes up to 42 to 52%, and higher grade notching is a little bit rare, between 16 and 44%. So the scapular notching is a frequent finding, and we're not sure whether it's a problem or it's inherent in the design of a reverse total shoulder. There are a lot of approaches how to avoid this notching. And the one that's favored in the most cases is moving the base plate as inferior as possible. So the glenosphere is overlapping a little bit, 2 to 3 millimeters. If you move it down, you increase the possible abduction, as you can see here. But there are ideas how you can avoid this notching. If you use 135 degrees instead of 155 inclination on the humeral side, you will have less notching and you will have less tensioning of the glenoid. So this might be beneficial. Though the pros, if you use 135 degrees instead of the classic Grammont design with 155, is that you have better external rotation because the lever arm for the infraspinatus, if it's still there, and the teres minor is better, and you will have less notching because it doesn't touch the scapular neck so early in adduction. There have been some concerns about this. If you measure it biomechanically, you will have less abduction, and there was a fear of higher rate of dislocation. This was examined in studies by Eriksson, and he could show that you have better external rotation and less notching, but he couldn't find a clinic relevant reduction of abduction, and he couldn't find higher rates of dislocation. The other new concepts to avoid the problems, and this is the inversion of the material at the glenosphere and the metaglen. Traditionally, we have the polyethylene on the humeral side and the metal and the hard surface and the glenoid side. And there are approaches by some companies that change this material. So you have the polyethylene and the glenoid side, and a ceramic, for example, with less wear as metal on the humeral side. Is this of any use? You can look at this image of the polyethylene insert, and the main problem is not the joint wear, just the regular wear you have by moving this joint. But if you have an impingement at the scapular neck, then the wear increased tremendously, as you can see here. And this also increases with the amount of inlay that you have on the humeral side. If you have very low amount of inlay with the 0 insert, you have much less notching wear as you have with this +6 millimeter component. You can also measure the amount of wear, and it has been shown that if you use cross-linked polyethylene, that's even combined with vitamin E to avoid aging, and combine this with a ceramic, you will have a reduction of wear of 80%, and that's a lot. What do the registries tell us about the revisions? The revision rates are less problematic regarding the cementless fixation of the shaft and the base plate than they are in total shoulder arthroplasty, meaning there's no difference whether you cement or you use uncemented stems. And as you know, on the glenoid side, it's always cementless in the reverse total shoulder arthroplasty. Males have higher revision rates, maybe because of the higher forces of the muscles. And if you look at the reasons for revisions, also the same reason as in total shoulder, anatomic total shoulder, the main reason is instability, followed by infection and loosening, and finally fracture and pain. So instability is an issue in reverse total shoulder arthroplasty. And we can avoid inherent instability by avoiding too small glenospheres. It has been clearly shown in the registries that if you use a glenosphere smaller than 38 millimeters, you will have increased rates of dislocation. What are surgical tips and tricks for putting in a total shoulder? From my experience, there are 3 issues that are important. First one is exposure. Second one is exposure. And the third one is also exposure. And you need some experience when you put this in. You should know the implants and your instrumentation. And you will only be a specialist if you've seen every complication in a very narrow field of medicine. So for reverse total shoulder, the surgical pearls are not to cut the axillary nerve that crosses around the glenoid neck from anterior to posterior, and the junction of the muscle and the tendon of the subscap. And this can be hurt when you do your inferior and posterior capsular release. So you should always stay to the bone and do your release very cautiously, maybe with the electrocautery device, so the nerve and the muscle jumps when you come close to the nerve. It's important not to put in the glenoid component in superior tilt, because this results in shear stress on the glenoid base plate, and finally this results in glenoid loosening. So make sure that you remove the inferior osteophyte. So let me sum up. We have some downsides of the reverse total shoulder that we should keep in mind. If we use the 155 angle device, you might have decreased function after 6 or 7 years due to a fatigue of the deltoid. The 155 designs have inherently high rates of notching, and maybe because of this loosening after 8 years. The modern designs address these problems and try to solve these. Reverse total shoulder arthroplasty can improve quality of life tremendously, and the patients and the surgeons love it. So thank you very much for the attention, and I'll be here for your questions now.
Thank you, Philip. Brilliant presentation and a lot of insight into both anatomic as well as reverse shoulder arthroplasty. Just a few questions. In the setting of a proximal humerus fracture, and you are planning to do an arthroplasty, why do you prefer a reverse shoulder, or do you prefer a total shoulder? And what is the reason?
So the question is, to make sure that I understood correctly, if you have a proximal humeral fracture, what I would suggest, anatomic total shoulder or a reverse design?
Yeah, well, in case you're preferring arthroplasty, because there are a lot of other options as well. For example, if you can treat by a locking plate as well, isn't it? So in case you've decided to do an arthroplasty.
So that's true. You can do a proximal humeral fracture, as you know, non-operative with plate or with total shoulder. And if I decide to do a reverse total shoulder, an arthroplasty, I always would prefer a reverse total shoulder arthroplasty, because the results are much more reliable. The healing of the tubercles are much safer, and the incidence of healing is much higher than with hemi total shoulder arthroplasty. This has been shown in multiple studies. So if you decide for an arthroplasty, I would recommend reverse.
Okay, thank you for that. And do you think the complication rates in general for reverse shoulder is very high? For example, if you're treating cuff tear arthropathy, and that's a classic indication for reverse shoulders, and suppose you're treating it for proximal humerus fracture, do you think there's a higher rate of complications when compared to cuff tear arthropathy?
Though the rate of complications are lower in cuff tear arthropathy compared to the fracture treatment, because you don't have the fracture hematoma, you don't have the problem of healing of the tubercles because they are not gone. So this is pretty clear, and in the data that the revision and the complication rate for fracture reverse totals is higher than in cuff tear arthroplasty. And the reason are obvious, because you don't have the healing of the tubercles and you don't have the trauma.
Thank you for that, Philip. And just a last question before we wind up the session. Are there any precautions that you need to take, especially in the post-operative period, that you need to restrict any particular moment? For example, you do a hip arthroplasty, sometimes we give advices, right? So that you do not do a particular movement or something like that. And what about reverse shoulder? In the post-operative period, any particular precaution?
Well, it depends on the approach that you used. If you have a fracture case, then you have to be very cautious to avoid dislocation of the tubercles. This has to be outweighed between the range of motion that you don't want to lose, but you want to have the healing of the tubercles. So at the first 6 weeks, when you want to have the healing of the tubercles, my approach is to do very cautious range of motion exercises and to increase this degree and amount of force that you apply only after 6 weeks. This is different to the degenerative diseases. When you put in a total shoulder, an anatomic one, then you have to make sure that the subscap is healing, because if you want to implant the total shoulder, you have to cut the subscap, and this has to heal. If this doesn't heal, then it will cause an instability and you have to revise it. So in the first 6 weeks, it's also important to limit external rotation up to 0 degree and to avoid much force in internal rotation so the subscap can heal properly. In the reverse total shoulder, if you put it in cuff tear arthroplasty, you can be a little bit more aggressive because of the semi-constrained design. I always try to reattach the subscapularis anteriorly, because it has been shown that this reduces the rate of dislocation. But it also works because of the semi-constrained design if it doesn't heal 100% in the anterior part, like the subscap is not healing perfectly. So for the reverse total shoulders, you can be a little bit more aggressive in rehab. That's my experience.
Okay, that's all the questions that we have, Philip. It was a fantastic session, a lot of new learning, and good to listen to you, your experience on anatomic as well as reverse shoulder. Thank you for joining in, Philip.
Yeah, thank you for having me, and have a good time and stay healthy, everybody. It was a great pleasure seeing you